Now we are going to discuss arterial disorders. In arterial disorders, first we are going to discuss peripheral arterial occlusion. So we are going to discuss peripheral arterial occlusion. Okay. So what is the problem? Because of arterial occlusion, there is ischemia. And one simple principle which you have to remember, that ischemia anywhere in the body leads to pain. So whenever there is peripheral arterial occlusion, it is characterized by 5 P's. So what are those 5 P's? 5 P's. First and most important, it is pain, there is pallor, there is pulselessness, there is paralysis and paresthesia. There is paralysis and paresthesia. Clear? So it is characterized by 5 P's: pain, pallor, pulselessness, paralysis, paresthesia. Out of these 5 P's, which one is most common? So the most common is pain. It's the pain. Sometimes a 6th P is also added. And what is that 6th P? It is poikilothermia. So sometimes the 6th P is added, and that is poikilothermia. So these are 5 P's of peripheral arterial occlusion. Now see, what's the most common cause of peripheral arterial occlusion? The most common cause is atherosclerosis. I want to tell you that in majority of arterial disorders, directly or indirectly, one of the most common causes is atherosclerosis. Now see the questions. Atherosclerosis is the most common cause of peripheral arterial occlusion. It is the most common cause of subclavian artery stenosis. It is the most common cause of extracranial aneurysm. And the most common degenerative disorders of vessel is atherosclerosis. Clear? So what is the most common cause of peripheral arterial occlusion? The causes of peripheral arterial occlusion, and the most common cause is atherosclerosis. Okay. So atherosclerosis, it's the most common cause. Okay. Now see, cause which is exclusively seen in young male smokers age less than 40. Leading to peripheral arterial occlusion, and this condition is Burgess disease. So this is Burgess disease, which is also known as thromboangiitis obliterans. Now we are going to compare. Most common cause is atherosclerosis. So relatively, which one is more common? Atherosclerosis is more common. Clear? Generally, it is seen in which particular age group? So it is seen in 6th to 7th decade. Clear? And which vessels are involved? In atherosclerosis, large and medium sized vessels are affected. So what are those? Large and medium sized vessels. Clear? So what are those vessels? It is obviously abdominal aorta, just below that iliac artery, after that there is femoral artery, and what else? Popliteal artery. Clear? So these are the large and medium sized vessels which are affected, and generally you can see the vessels aorta, iliac artery, femoral, popliteal. So which limb is more commonly affected? Obviously it's the lower limb. So lower limb is more commonly affected in atherosclerosis. Now coming to Burgess disease, see the patient profile. Exclusively it is seen in males, smokers, and age less than 40 years. Patient profile, very, very important. Exclusively seen in males, smokers, age less than 40 years. In Burgess disease, there is involvement of medium and small sized vessels. So there is involvement of what? Medium and small sized vessels. Clear? And what are those vessels which are involved? The mnemonic is TPR. So TPR, so this is tibial, plantar, radial. Clear? So tibial, plantar and radial. These are the vessels which are involved. Clear? So you can see here, tibial plantar, these are present in the lower limb. Radial artery is going to supply the upper limb. So Burgess disease can involve both lower limb as well as upper limb, and it is more common in lower limb. Clear? So this is also more common in lower limb, but it can be seen in upper limb. Now see, in peripheral arterial occlusion, the manifestations depend on the site of occlusion. Okay, and imagine if the artery is going to supply a muscle also, so what will happen? In that muscle there is claudication. So manifestations are dependent on the site of occlusion. Now let's discuss it. Now see the anatomy. You can see this is aorta. Okay, this is common iliac. Common iliac is going to divide into internal iliac. So this is internal iliac and this is external iliac, and this is common femoral, this one is superficial femoral, this is popliteal. Okay, now first imagine that there is obstruction at aortoiliac bifurcation. So if obstruction is at aortoiliac bifurcation, there will be claudication in the muscles located distally. That's why you will notice that whenever there is obstruction at aortoiliac bifurcation, it is also known as aortoiliac disease. This is known as aortoiliac disease. And in this aortoiliac disease, you will notice claudication in which region? So there is claudication in buttock or gluteal region. There is claudication in thigh and claudication in calf. So there is claudication in buttock, thigh and calf. One second. If obstruction is at aortoiliac bifurcation, it means both external as well as internal iliac blood flow is reduced. Internal iliac is going to supply the pelvic organs. And if you see the physiology of erection and ejaculation, see, erection is because of parasympathetic system. So there is increased blood flow to the penis during erection, and ejaculation is because of sympathetic system. So during erection, there should be increased blood flow to the penis. But the problem, if there is obstruction at aortoiliac bifurcation, what happens? There is decreased blood flow to the penis. So what happens? There is erectile dysfunction and it can lead to impotence. So what is the name of this syndrome? It was asked 2 to 3 times in names, and this is known as Leriche syndrome. So if obstruction is there at aortoiliac bifurcation, what happens? There is erectile dysfunction, and this erectile dysfunction can lead to impotence. Erectile dysfunction, it can lead to impotence. Clear? This is known as Leriche syndrome. This was the question in AIIMS. Okay, and in NEET PG 2020 there was one question that if a patient is having claudication in the gluteal region, which of the following artery is obstructed? So obviously if gluteal region is having claudication, so obstruction will be a bit higher. So which vessel is affected? Aortoiliac bifurcation. So which disease is there? In buttock claudication, the patient is having aortoiliac disease. Imagine if the obstruction is at the level of common femoral. So if patient is having obstruction at the level of common femoral, so there will be claudication in thigh and calf. So there is claudication in thigh and calf. If there is obstruction in superficial femoral, popliteal or crural arteries. Clear? So obstruction in superficial femoral, popliteal, crural arteries. So what happens? There is claudication. So where is the claudication? Patients will be having calf claudication. Clear? So the manifestation will be dependent on the site of occlusion. Now see the important points related to embolic occlusion. Okay. So what is embolic occlusion? So first, what is the definition of embolus? It is detached thrombus from the heart or more proximal vessels. So what is embolus? Embolus is detached thrombus, okay, from heart or more proximal vessels. So question which is frequently asked, that what is the most common source of embolus? And this patient, you have seen in the medicine that the patients who are having atrial fibrillation, and if patient is having atrial fibrillation, there is increased risk of formation of thrombus in left atrium. So the most common source is left atrium, followed by mural thrombus, and the mural thrombus is seen in the patients of myocardial infarction. So what's the source? Most common source of embolus, and it's the left atrium. Generally, in which patients? In the patients of atrial fibrillation, followed by mural thrombus. And mural thrombus is generally seen in which patients, are present in which patients? Patients of myocardial infarction. Okay. Now see, in embolic occlusion, the manifestations are dependent on the organ involved. Now see the organs involved and what are the manifestations. So generally in old days you have seen that certain patients who are having embolic occlusion and of the vessels which are supplying the brain, these patients have stroke, or sometimes these patients have transient ischemic attack. So in the brain, what are the manifestations? It can lead to stroke or it can lead to transient ischemic attacks. If there is embolic occlusion of artery supplying the retina, so what happens? There is amaurosis fugax. Amaurosis fugax. We will discuss that because of embolic occlusion of mesenteric vessels, there is acute mesenteric ischemia. And if there is acute mesenteric ischemia, what will happen? There is pain. Clear? So later it can lead to gangrene of small bowel. So what happens if there is involvement of mesenteric vessels? So in these patients, there is acute mesenteric ischemia leading to ischemia and gangrene of bowel. In majority of cases, superior mesenteric artery is involved. That's why small bowel is affected in majority of cases. Whenever there is embolic occlusion of the artery supplying the spleen, so there will be splenic infarction, and because of this infarction, there will be local pain. And if kidney is involved, what happens? There will be loin pain and the patients will also be having hematuria. So it can lead to loin pain and hematuria. So here you saw that the manifestations are dependent on the organ involved. Now see, embolic occlusion, this is an emergency situation, and that's why in majority of cases we are going to make the diagnosis clinically, means on the basis of manifestations. Okay, so generally how we are going to make the diagnosis? It's an emergency situation, so diagnosis is made clinically. Okay, so see what are the manifestations. First, you will find that there is source of emboli. So certain patients are having atrial fibrillation, patients are having arrhythmia or myocardial infarction. Second, we discussed that in peripheral arterial occlusion, patients are having history of claudication. But since this is acute episode here, there is no such history. So we have evidence of source of emboli. So there must be some source of emboli. Generally, there is no history of claudication. Why? Because this is an acute episode. Because of ischemia, what happens? There is severe pain and numbness in the limb. So it can lead to severe pain and numbness in the limb if it's involved. Okay, movements are painful, and distal to occlusion, pulses are not palpable. So distal pulses are not palpable, so there is painful movement. So movement is painful. Clear? And distal pulses are not palpable. These are not palpable. Clear? So diagnosis is made clinically because this is an emergency situation. This is an emergency situation. That's why we have to start IV heparin. And how much unit is given? 5,000 units. So see the management. It's an emergency situation, so we have to start IV heparin. And generally we give 5,000 units of IV heparin. Okay, so this heparin is going to reduce the extension, so it decreases the extension, and second, it is going to maintain the patency, so it maintains patency. Now tell me, what is the name of this catheter which is used to remove the embolus or thrombus? If we are removing the embolus, this is known as embolectomy, and if we are removing the thrombus, this is known as thrombectomy. So what's the name? Can you see the balloon at the tip here? This is known as Fogarty embolectomy catheter or balloon catheter. So what's the name? This is Fogarty balloon catheter. And if it is used for removal of embolus, that's known as embolectomy, and thrombus, that's known as thrombectomy. So how we do it? Have a look. Now imagine in this artery there is a thrombus or embolus. So there is embolus is localized. So we can insert this Fogarty balloon catheter proximal to the embolus, or if we are inserting it from the proximal direction, distal to the embolus. So when you insert this Fogarty balloon catheter proximal or distal to embolus, after that what you do? You inflate the balloon, and when we are going to inflate the balloon, we are going to pull the catheter, and what will happen? Yes, the embolus will come out. Now see here in this diagram, you can see in the first condition there is one thrombus located at aortoiliac bifurcation, involving mainly the right iliac. So what I'm going to do here, you can see that I'm going to insert this Fogarty balloon catheter, clear? And it is inserted proximal to the thrombus. Then I'm going to inflate the balloon and going to withdraw the catheter. And when I'm going to pull the catheter, here you can notice that what? The thrombus is taken out. So thrombus comes out. So in this diagram, can you see we are using Fogarty balloon catheter on both sides, inserting it proximal to the thrombus or embolus, inflating the balloon, and going to withdraw the catheter so that we are going to remove the thrombus or embolus. So this is how we manage the patients of embolic occlusion. Next condition, which is very important and frequently asked, this is known as Buerger's disease. Buerger's disease. Okay, what is the other name of Buerger's disease? It is also known as thromboangiitis obliterans. So what's the other name? This is also known as thromboangiitis obliterans. Clear? So in short, we call it as tau. Clear? Now see, it is segmental inflammatory disease of vessels which is going to involve medium and small size vessels. So if it is segmental inflammatory disease, it means whole vessel is not involved. There are segment of vessels which are involved, and in between there are normal areas. So it is also having skip lesions or skip areas. So it is characterized by segmental involvement of vessels. So it is segmental inflammatory disease. Clear? It means with skip lesions. So another important point, which vessels are involved? We discussed it is going to involve medium and small sized vessels. So it is going to involve medium and small sized vessels. So we discussed what was the mnemonic, and the mnemonic was TPR. Clear? So there is involvement of tibial, plantar, radial. It means both lower limb and upper limb is involved. More commonly it is going to involve the lower limb. We discussed the patient profile, exclusively seen in males, in smokers and age, males, smokers, age less than 40 years. Clear? This is the patient's profile. Buerger's disease is asked in pathology also, and sometimes the question related to pathology is asked in surgery also. Now see the name. The name of this condition is thromboangiitis obliterans. It means in the vessels initially there is thrombosis, means there is obstruction, followed by angiitis, means there is inflammation. Imagine this is an artery. This is an artery. This is a vein, and this is a nerve. Clear? See, initially there is thrombosis in the artery. After that, what happens? There is angiitis. Angiitis means there is inflammation, and this inflammation is ultimately going to involve all the three structures. And after that, what happens? There is permanent occlusion or obstruction. So thromboangiitis obliterans. So initially inflammation is involving artery, but later all the three structures are involved. So important point, in thromboangiitis obliterans, ultimately there is involvement of artery, vein and nerve. So ultimately this inflammatory process is going to involve all the three structures. And what is the extent? Generally the disease process starts distally and then it progresses proximally. So generally it progresses from distal to proximal direction. So generally it extends or progress from distal to proximal direction. So what are the clinical manifestations? It is characterized by a triad. And what's the mnemonic? RIM. Characterized by a triad. Mnemonic is RIM. So the full form, R means Raynaud's phenomena, I means intermittent claudication, and M means migratory superficial thrombophlebitis. Clear? This is the triad of Burgess disease. In NEET PG 2020, there was one question related to intermittent claudication. Clear? Question related to intermittent claudication. Okay, and it's very easy to understand. See, so generally the pain of intermittent claudication is there when the muscle is working or patient is doing some kind of work or exercise. So the question was there in the NEET PG that intermittent claudication is present at the time of work or at the time of rest. So obviously it is present when the muscle is working. So it's present at the time of work or at the time of exercise. Second question was there. In the same question, the second option was there that generally it is seen in daytime or night. So in night, patient is usually relaxing or taking rest. So usually daytime. Okay. Now see, whenever this patient is going to walk for some distance, then only the symptoms of intermittent claudication are going to arise. This fixed distance is known as what? Claudication distance. It is not variable, it is fixed. So what? Generally it appears for walking for certain distance, and that's known as claudication distance. And this claudication distance is almost fixed for the patient. Clear? But when the disease is going to progress over a period of time, it is going to decrease. Okay, but generally it is fixed. So claudication distance is fixed, and these three options were there in NEET PG 2020 related to intermittent claudication. Okay, there is another question related to intermittent claudication, and that's Boyd's grading of intermittent claudication. What's the Boyd's grading? This Boyd's grading of intermittent claudication, this is also frequently asked in NEET PG. So there are 4 grades. Initially patient is going to tell you that, sir, when I start the walking or whenever I start the walking, there is pain. But if I continue to walk, pain disappears. So pain appears at the start of walking and it disappears if patient continues to walk. Why? Because whatever the substance P which was collected, it is washed away because of increased flow. In grade 2, patient can walk with pain. In grade 3, pain compels the patient to take rest. And when patient is having rest pain, it is grade 4. So this is Boyd's grading of intermittent claudication. Now see, it's an arterial disease mainly. So how we are going to make the diagnosis? Diagnosis, investigation of choice for diagnosis. It's angiography. Now we have to perform the angiography of lower limb or upper limb. We discussed that TPR, tibial plantar radial, these vessels can be involved. It means both upper limb and lower limb vessels are involved. So that's why we go for forelimb angiography. So investigation of choice, we go for forelimb angiography. Okay, and we discussed one concept many times, that if there is some occlusion occurring over a period of time, there is development of collaterals. So what kind of collaterals are seen in Burgess disease? There is presence of corkscrew collaterals. What kind of collaterals? So there is presence of corkscrew collaterals. So in Burgess disease, there is presence of corkscrew collaterals. In patients of Burgess disease, we calculate ankle brachial pressure index also. So this is known as ABI or ABPI, ankle brachial pressure index. So what is this ABI or ABPI? It's the ratio of systolic blood pressure. This is the ratio of systolic blood pressure at the ankle and in the arm. So ankle brachial pressure index is the ratio of systolic blood pressure at the ankle and in the arm. Okay, now simple question. Generally, ankle brachial pressure index should be more than 1 or less than 1. So you know that there is some effect of gravity in the lower limb. Clear? So because of that, the pressure is slightly higher in the lower limb as compared to upper limb. That's why ankle brachial pressure index should be more than 1. Right? If it is less than 1, it means it signifies that patient is having obstruction in the blood flow of the lower limb. So it signifies the disease. Now see the interpretation. Imagine that ankle brachial pressure index is 0.1 to zero point 0.4. If it's 0.1 to zero point 0.4, it means there is critical limb ischemia. This is the question which is frequently asked. This table is from Schwartz, so you have to follow this one. Value 0.1 to zero point 0.4, it is suggestive of critical limb ischemia. If the value is 0.5 to zero point 0.9, this is suggestive of intermittent claudication. So this is suggestive of intermittent claudication. This question is also frequently asked. What's the normal value? So the normal value is 1 to 1.2. So can you see here? 1 or more than 1 is normal. But certain patients are having calcified vessels. And if the patient is having calcified vessel, it's very difficult to compress that vessel with the probe. And in those cases, it is more than 1.2. So this is abnormal. So if a patient is having calcified vessel, it's more than 1.2. Clear? So generally in which cases you are going to find calcified vessels? This was asked in NEET PG and it is seen in diabetes mellitus and end stage renal disease. Clear? So you have to remember this one, frequently asked. In exam, sometime examiner is giving the value ankle brachial pressure index less than 0.5. So less than 0.5 means 0.1 to zero point 0.4 and it signifies what? Critical limb ischemia. So this table you have to remember and this is taken from Schwartz. There is Fontaine staging which is used for limb ischemia and this is also important. So Fontaine staging. This is Fontaine staging of limb ischemia. Clear? And it is going to signify or going to tell us that how the disease is going to progress. So what's the stage 1? In stage 1, patients are asymptomatic. So stage 1, no symptoms. Clear? After that, patient starts developing intermittent claudication. And if patient is having mild intermittent claudication, stage is 2A. And if patient is having moderate to severe intermittent claudication, it is stage 2B. So see, what's the stage? 2A and 2B. In 2A, there is mild intermittent claudication and in 2B, there is moderate to severe intermittent claudication. Clear? What happens in stage 3? Patient develops rest pain. And in stage 4, patients are going to develop critical limb ischemia. Critical limb ischemia means this patient is going to develop what? Ulceration or gangrene. So what's the stage 3? In stage 3, there is rest pain. There is rest pain. And in stage 4, there is critical limb ischemia, and which is going to progress to ulceration and gangrene. Ulceration and gangrene. Clear? So you have to remember this staging. So one very important point, patient is going to tell you in the history that, sir, whenever I'm going for the sleep, generally I hang my legs by the side of bed and I used to take rest in the sitting position. So why this patient is going to hang the legs by the side of bed? Because there is pain because of ischemia. So patient is going to hang the legs by the side of bed so that with the help of gravity there is increased flow to the ischemic tissues. Clear? So that's why you will find this characteristic history of Burgess disease. How we are going to manage? So it is exclusively seen in male smokers age less than 40. So first and most important thing is abstinence from smoking. So see the management. So most important step is abstinence from smoking. Okay. What is the problem? In certain patients, whenever we perform even amputation and we ask the patient that you are not supposed to smoke, we have found that even today patient is planned for amputation and in the morning patient is smoking in the park. Clear? So first, abstinence from smoking. Second, we give vasodilators, though vasodilators are not very helpful. So what are the agents we give? One is xanthinol nicotinate and the second is pentoxifylline. So the agents, you have to remember the name, xanthinol nicotinate. What is the brand name? Sometimes they ask this brand name also. This is complamina. Complamina. And the second agent which we give, that's pentoxifylline. Pentoxifylline. And what's the brand name of pentoxifylline which we give? It's Trental. They ask these two questions also. But vasodilators are not very helpful. Second, the patients who are having rest pain, for rest pain only, we go for lumbar sympathectomy. So in these patients, we go for lumbar sympathectomy, and this lumbar sympathectomy is done for which patients? It's done for the patients who are having rest pain. Rest pain. There is another option which is very cumbersome procedure. We can go for omental transposition. Omental transposition. And if patient is having gangrene, in those cases amputation. So amputation is done for gangrene. This was the image-based question in NEET PG, that the patient is having Burgess disease and presented to your emergency with this manifestation. What should be done? So since this patient is having gangrene, we have to go for amputation. Okay. One topic which is frequently asked in detail in relation to Burgess, and that is lumbar sympathectomy. And it's very easy to understand the concept. See, what is the problem? Why we perform sympathectomy? Because whenever there is activation of sympathetic system, it leads to vasoconstriction. Clear? So when there is vasoconstriction, then only what happens? There is rest pain. Rest pain is because of cutaneous ischemia. Rest pain is because of cutaneous ischemia. Okay? And the blood supply of the skin is under sympathetic control. But if we are talking about the blood supply of muscles, blood supply of muscle is not under sympathetic control. That's why whenever there is intermittent claudication because of ischemia of muscles, lumbar sympathectomy is not helpful. So lumbar sympathectomy is performed for rest pain. It is not performed for intermittent claudication because the blood supply of muscles is not under sympathetic control. Okay, what we do in lumbar sympathectomy, have a look. So in lumbar sympathectomy, there are L1 to L5 ganglia. So we remove L1 to L4. So on one side, so in lumbar sympathectomy, we are going to remove L1 to L4 ganglia from the affected side if the patient is having rest pain. But if we are supposed to perform bilateral lumbar sympathectomy, at least L1 should be preserved. on one side. Okay, so if we are planning to perform bilateral lumbar sympathectomy, in that case at least L1 should be preserved on one side. Why? See, it's easy to understand. This is bladder, this is prostatic urethra, this is urethra, this is vas deferens, this is testis. Now see, this is external urinary sphincter and this is internal urinary sphincter. This internal urinary sphincter is under sympathetic control. Which ganglia? L1. Now see the physiology of erection and ejaculation. Erection is because of parasympathetic system and ejaculation is because of sympathetic system. So at the time of ejaculation, what happens? Can you see? The semen goes from vas deferens into urethra, prostatic urethra, and then it goes out. Okay. To prevent the retrograde ejaculation, means the passage of semen into the bladder, internal urinary sphincter is closed. So at the time of ejaculation, this is closed so that the semen is going out. But what is the problem? Any situation in which this L1 sympathetic ganglia is removed, or this internal urinary sphincter is injured, or this is a smooth muscle, it is relaxed. So in those cases, what will happen? Semen will go in the bladder and this is known as retrograde ejaculation. This is known as retrograde ejaculation. So in which cases you are going to find retrograde ejaculation? If you are performing bilateral lumbar sympathectomy, removing L1 to L4 bilaterally. First. Second, whenever we are going to injure this internal urinary sphincter, and we discussed it's very prone to injury in TURP, and this is smooth muscle. So third, whenever we are giving smooth muscle relaxants like alpha blockers. Clear? So after TURP, after the use of alpha blockers and after bilateral lumbar sympathectomy in which bilateral L1 to L4 is removed, we are going to find retrograde ejaculation. So this is one of the complications. Whenever we are performing lumbar sympathectomy, there are certain structures mistaken for lumbar sympathetic ganglia, and those structures are accidentally removed. And this question was also asked in NEET PG, that what are the structures which are accidentally removed during lumbar sympathectomy? And the mnemonic is Gujarat Premier League, GPL. So what are the structures accidentally removed? Structures accidentally removed during lumbar sympathectomy. So it's Gujarat Premier League, GPL, genitofemoral nerve, psoas sheath, psoas minor, and lymphatics. Very, very important. You have to remember genitofemoral nerve, psoas sheath, psoas minor, and lymphatics. So these are the structures accidentally removed during lumbar sympathectomy. Another question asked is the question related to indications of lumbar sympathectomy. Okay, so what are the indications of lumbar sympathectomy? This is very, very important. So it's very easy to understand. Any situation in which there is sympathetic activation leading to vasoconstriction. Any situation in which there is sympathetic activation leading to vasoconstriction, it will be helpful in all those conditions. So it is used in Burgess disease. Burgess disease is an indication. Which particular condition? It's the rest pain. So you have to remember rest pain in Burgess disease, atherosclerosis, Raynaud's disease, acrocyanosis, causalgia, hyperhidrosis, erythrocyanosis, and frostbite. These are the indications. Okay. So how to remember? Can you see? The mnemonic is Bara-Chef. So the mnemonic is Bara-Chef. Clear? So these are the indications for lumbar sympathectomy. Leg ulcers are frequently asked. So first see what are the typical sites of leg ulcers. You can see this is venous ulcer. Okay. And what is the typical location of venous ulcer? It is located in Gators area or Gators region. What is that Gators region? It's the area between malleolus and calf. So this is calf, this is malleolus, clear, or ankle. So this is the area. This area is known as Gators area or Gators region. So most of the venous ulcers are located here. And if you see the varicose ulcer, generally it is located just above the medial malleolus or 1 centimeter above the medial malleolus. So this is the location of venous ulcer. Now see the location of arterial ulcer. Arterial ulcers are typically located at the distal ends of the limbs. Where? Distal ends of the limbs. So arterial ulcers typically located at distal ends of the limbs. And distal ends where exactly? Generally over the lateral aspect in the lower limb and over the shin of tibia. So can you see the location? Anterior shin over malleoli under heel or toe. Clear? Now see neuropathic ulcers location. This is also known as pressure ulcer or pressure sore. So the locations: toe joints under metatarsal head, under heel or malleoli, and inner side of first metatarsal head. So these are the typical location. In detail, we are going to discuss what? Arterial ulcers. So generally it is located in the distal ends of the limbs over the lateral aspect of lower limb, typically located at shin of tibia or distal digits. Okay, so see, what's the cause of arterial ulcer? So in arterial ulcer, etiology is related to impaired blood flow. Simple. So there is impaired blood flow. Because of this impaired blood flow, what will happen? There is ischemia, and because of this ischemia, there is tissue death, and because of this tissue death, there is what kind of ulcer? Punched out ulcer. You want to see the shape? This is punched out. So there is punched out ulcer. Okay. Impaired blood flow can occur because of vascular occlusion. You know that in diabetes there is both microangiopathy and macroangiopathy. What's the problem in diabetes? In diabetes mellitus, there is both micro as well as macroangiopathy. And because of this microangiopathy and macroangiopathy, what's the problem? There is impaired blood flow and there is ischemia, there is tissue death leading to punched out ulcer. Now see how arterial ulcer looks like. Now see the location. It is located at the shin of tibia. Appearance, it's punched out. These ulcers are extremely painful. So it's punched out, extremely painful. There is impaired blood flow. So whenever we are going to palpate the distal pulses are not palpable. So generally in these cases, distal pulses are not palpable. Clear? And there are associated changes. What? You can see the skin. Skin is thin and shiny. Why? Because there is loss of subcutaneous fat. And if you see the hair, there is loss of hair. So here you can find that there is no hair. And what? If you notice the nails, nails are brittle. And here you can notice that there is amputation in one digit also. So what are the associated changes seen? Or it is associated with thin shiny skin. So why there is thin shiny skin? Because of loss of subcutaneous fat. There is loss of hair and brittle nails. Brittle nails. How we are going to make the diagnosis? So in arterial ulcer, diagnosis is generally made clinically. To assess the flow, we have to go for Doppler. So how we are going to make the diagnosis is the clinical diagnosis. So it's made clinically. Simultaneously, we perform what? Doppler. Doppler is done to assess the flow. Okay. What is the problem or what is the etiology? Etiology is related to impaired blood flow. So in the treatment, what should be done? We go for revascularization procedure. So see the management. In the management, generally, we go for revascularization procedure. Sometimes the ulcer is infected, and if there is infected ulcer, so if there is infected ulcer, in those cases, we go for debridement, and we give antibiotics. So we go for debridement, clear, plus we give antibiotics. So this is how we manage the patients of arterial ulcers. Now we are going to discuss arteriovenous fistula. Arteriovenous fistula can be congenital and it can be acquired. Out of congenital and acquired, which one is more common? It's the congenital arteriovenous fistula which is more common. But this is the very common mistake which students are going to do in the exam, that they are going to mark acquired. Why? Because most of the times hemodialysis fistula is revolving in their brain. So see, congenital is more common than acquired, you have to remember. It can be congenital, it can be acquired. Which one is more common? It's the congenital which is more common. You have seen many patients who are having AV malformations or AV fistula in the form of hemangioma, in the form of local gigantism. So congenital is very common. Certain patients are not coming to us because they don't have symptoms. Next question, that what is the most common cause of acquired AV fistula? And the most common cause of acquired AV fistula, it's penetrating trauma, because after penetrating trauma there is connection between artery and vein. So another important question, that what's the most common cause of acquired AV fistula? Acquired AV fistula, and this is penetrating trauma. It's the penetrating trauma. Clear? Okay, now we are going to discuss the iatrogenic AV fistula which we are going to create for the patients who are going for hemodialysis. Okay, one of the most commonly used fistula is Braccia semino fistula. So what are the iatrogenic fistula? These are frequently asked in the exam. Iatrogenic fistula, so these are created for hemodialysis. Very important, first is Braccia semino. So this is Braccia semino fistula. Okay, this Braccia semino fistula, it's between radial artery and cephalic vein. So it is created between radial artery and cephalic vein. So radial artery and cephalic vein. Second is snuff box fistula. Snuff box fistula is also created between radial artery and cephalic vein, but which branch of radial artery? It is created between posterior branch of radial artery. So second is snuff box. It's the snuff box fistula, and this snuff box fistula, it's created between posterior branch of radial artery and cephalic vein. Clear? So posterior branch of radial artery and cephalic vein. Simple. And the third is Feinberg fistula. This Feinberg fistula is created between radial artery and basilic vein. So you have to remember, third is Feinberg. So these named fistulas are frequently asked. Feinberg fistula. So this is in between radial artery and basilic vein. So how to remember? Feinberg, so is the brother of Zuckerberg, and you have to remember it with Facebook. Feinberg, Facebook. So F, Feinberg, B, basilic vein. Clear? So you can see the artery is same in all the three. Radial artery. In snuff box fistula, we are using posterior branch of radial artery. In Braccia semino and snuff box, the vein is same, cephalic. And in Feinberg, Facebook, so the vein is basilic. So these are the veins. Now see what is the pathophysiology, what's going to occur in the fistula. Imagine that this is a vein, and this is an artery. Okay, so what is the blood flow? In artery, it's away from heart, means from heart towards periphery, and in the vein, it's from periphery towards the heart. So whenever I'm going to create any kind of communication between artery and vein, this is fistula. What will happen? Yes, there is short circuit. So what's that short circuit? Rapidly, the blood from the artery starts going into vein. Why? Because how the flow occurs, flow of blood occurs, blood flows from the high pressure zone to the low pressure zone. So most of the blood from the artery starts going into the vein. And if most of the blood from the artery starts going to the vein, what happens? The venous return to the heart is increased or decreased. So you will notice that there is increased venous return to the heart. If there is increased venous return to the heart, what will happen? There is increased cardiac output. And if there is increased cardiac output, it means there is increased systolic blood pressure. Clear? In comparison to systolic blood pressure, the diastolic blood pressure is not going to rise that much. That's why what happens? These patients are having wide pulse pressure. So these patients are having what? Wide pulse pressure. Second thing in this diagram, you can notice that with pressure, the blood starts going where? Into the vein. Clear? So whenever we are putting our hand over the fistula, it feels like that some worm is passing beneath your hand, and this is known as what? Palpable thrill. At the site of fistula, you will notice that there is pulsatile mass. So what are the other changes? There is palpable thrill, palpable thrill. There is pulsatile mass, pulsatile mass at the site of fistula. Now what happens in chronic cases? Because under pressure the blood is going into the vein. So what will happen? The vein becomes dilated, tortuous, and the wall of vein is thickened. And these changes are known as arterialization of vein. So in chronic cases, you notice that in chronic cases there is arterialization of vein. What happens? Arterialization. Okay, so what are the changes in the arterialization of vein? The wall of vein is thickened. It's thickened. Vein becomes dilated and tortuous. It becomes dilated and tortuous. Okay, now see one sign which was asked minimum 20 to 30 times in exam. Imagine that this is the site of fistula. You can see this is the site of fistula. So whenever I'm going to compress the artery proximal to fistula, so whenever you are going to compress the artery proximal to fistula, first the palpable thrill disappears, size of pulsatile mass is going to decrease, and what will happen? There will be relative decrease in the heart rate. Clear? So what happens? What's the name of this sign? This is known as Nicola-Doni or Branham sign. This was asked many times. So what is this? Nicola-Doni or Branham sign. So this is Nicola-Doni or Branham sign. Okay. So in this case, compression of artery proximal to fistula. On compression of artery proximal to fistula, what happens? So on compression of artery proximal to fistula, first thrill disappears, palpable thrill disappears. Second, what happens to the size of pulsatile mass? There is decrease in the size. So decrease in size of pulsatile mass, and there is decrease in heart rate or normalization of heart rate. So this is known as Nicola-Doni Branham sign. Now see how we are going to make the diagnosis. The diagnosis can be made by angiography also, and it can be made by duplex scan also. But which one is investigation of choice? It is angiography. Why? Because angiography is both diagnostic and therapeutic. The patients who are having small fistula, with the help of angiography, we can embolize that. Clear? So how we are going to make the diagnosis? Investigation of choice for diagnosis, and it's the angiography. Okay, and how we are going to treat it? If there is small fistula, we can go for embolization, but if the fistula is large, in those cases we have to go for surgical ligation. So what's the treatment for small fistula? For small fistula we go for embolization, Clear? And for large fistula, we go for surgical ligation. Clear? So for large fistula, we go for surgical ligation. So this is how we are going to manage the arteriovenous fistula. Now we are going to discuss thoracic outlet compression syndrome. Okay, so see what happens here. You can see the relation. These are the nerves of brachial plexus, and this is subclavian vein, and this red colored structure is subclavian artery. So this is what thoracic inlet, and this is thoracic outlet. So in this case, what you can see, this is the first strip. So there is relation of subclavian vessels and nerves of brachial plexus over the first strip. So in this case, there is compression of nerves of brachial plexus and subclavian vessels at thoracic inlet, and it is known as thoracic outlet syndrome. So it's a misnomer. Why? Because the compression is occurring at the thoracic inlet. So first important point, it is characterized by compression of nerves of brachial plexus, okay, and subclavian vessels, means subclavian artery and vein, subclavian vessels, where? At thoracic inlet. So it's a misnomer. At thoracic inlet. So it's a misnomer. Generally, it is more common in females. Which particular females? Middle-aged females. So it's more common in middle-aged females. Okay, and there are two forms. See, if there is compression of the nerve of brachial plexus leading to manifestation, this is known as neurogenic form, and if there is compression of subclavian artery or subclavian vein, this is known as vascular form. So two forms, neurogenic form and vascular form. Which one is more common? It's the neurogenic form which is more common. First important point. So two forms, there is neurogenic form and second is vascular form. Which one is more common? It's the neurogenic form which is more common. Okay. Second, the obstruction or the compression at thoracic inlet, it's dynamic, not static. Dynamic means in one particular posture it is more marked, and there might be possibility that patient is not having symptom in some other posture. So it's a dynamic compression, and if it's a dynamic compression, it means this is diagnosed by provocative test. Radiological investigations are not very helpful. So another important point, that compression in thoracic outlet syndrome, the compression in thoracic outlet syndrome, it's dynamic, and since it's dynamic compression, that's why how we are going to make the diagnosis, it is diagnosed by provocative test. Okay, now see, in middle-aged females, what happens? There is atrophy of shoulder girdle, atrophy of muscles around the thoracic inlet. This can lead to the thoracic outlet syndrome, and certain situations in which something extra is located here. Something extra means, you can see this is the first rib and the relation. Clear? So what is extra thing here in the neck? Cervical rib. If some lymph node is there, some tumor is there, Pankos tumor, osteoarthritis is there, if cervical hematoma is there, so anything which can compromise the space of thoracic inlet can lead to thoracic outlet syndrome. So what are the predisposing factors? Predisposing factors for thoracic outlet syndrome. The predisposing factors are cervical rib, or sometimes there is abnormal first rib or fibrous band. If there is long transverse process of cervical vertebra, which one? C7. Patients who are having osteoarthritis, Pankos tumor, cervical hematoma, all these are going to compromise the space at thoracic inlet and going to increase the risk of thoracic outlet syndrome. Now see what are the clinical manifestations. So it's very easy to remember. This is the first rib, and these are the three structures in relation: nerves of brachial plexus, subclavian artery, subclavian vein. So the most commonly affected root value is C8T1. And if the root value is C8T1, what is the nerve which is involved? ulnar. So most commonly involved nerve is ulnar. So see the supply. This patient is coming to us and patient is complaining of pain and paresthesia over inner aspect of forearm and hand. And whenever we are going to examine the hand, you are going to notice that there is atrophy of hypothenar and interossei muscle. Clear? Second, if there is compression of artery, so the patient will be coming with one of the 5 P's. There will be pain, pallor, paralysis, pulselessness, paresthesia. Pain is there. And sometimes when there is compression of the subclavian vein, what happens? The venous drainage is compromised and these patients are having collection of deoxygenated blood. Because of that, what happens? There is pain, there is edema and bluish discoloration, that's known as cyanosis. So see the clinical manifestation, clinical features. So first, what happens in neurogenic form? Neurogenic form. Okay. So here, the most commonly involved root value is C8T1. So most commonly involved root value C8T1. Most commonly affected nerve, it's ulnar nerve. Ulnar nerve. And that's why, what are the complaints of the patient? There is pain, there is paresthesia, pain and paresthesia. Where exactly? Inner aspect of forearm and hand. So pain and paresthesia over inner aspect of forearm and hand. Okay, one. Second, these patients have atrophy of hypothenar and interossei muscle. So there is atrophy of hypothenar and interossei muscle. Okay, hypothenar and interossei. Okay, in vascular form, when there is involvement of subclavian artery, the patient will be coming with one of the 5 P's, at least one of the 5 P's, and generally there is pain. Pain is there. So there is pain, pallor, pulselessness, paralysis, paresthesia. And whenever there is compression of subclavian vein, because of this, there is collection of deoxygenated blood, impaired venous drainage, and because of that, patient is going to develop pain, edema, and the bluish discoloration, and that's cyanosis. Clear? So patient may develop one of the presentations of these things. So we discussed how we are going to make the diagnosis. Generally, it is made by provocative test. If patient is having some kind of radiological abnormality like cervical rib, some tumor is there, we can make the diagnosis radiologically. But in majority of cases, since the compression is dynamic, we are going to make the diagnosis by provocative test. So how we are going to make the diagnosis? Compression is dynamic, so it is diagnosed by provocative test. Okay, in exam they are asking the names of these provocative tests. So what are the names? First is Adson test. What's the other name of Adson test? It is also known as Scaleni test. So the other name is Scaleni test. Clear? Costoclavicular test is also known as military position or Halsted test. So what's the name? It's the military position or Halsted test. It's Halsted test. Clear? Hyperabduction test is also known as Wright test. So what's the other name? It's also known as Wright test. And this Roos test is also known as arm claudication test. So what's the name? It's known as arm claudication. Arm claudication test. So these are the various names. So this was the video based question in names. Here you can see the shoulder of patient is drawn backwards. The arm is at the level of shoulder and you can see the elbow is flexed at 90 degree and here patient is doing this kind of exercise. Okay, so in hand patient is doing exercise. So patient is doing exercise. So if there is appearance of pain or numbness in the hand because of exercise, this is known as what? Roos test, and it signifies what? That patient is having thoracic outlet syndrome. So this is the Roos test, which was a video based question in the AIMS. So in this Roos test there is numbness numbness and pain in hands. Pain in hands with exercise. Clear? This was the video based question. So these are the provocative tests. Now see, in majority of patients, especially the patients who are having neurogenic form, these patients are managed conservatively and they improve after conservative management. So see the management. So more than 90% patients, more than 90% patients of neurogenic form, these patients improve after conservative management. So what kind of advice is given to these patients? We advise these patients for improvement in postural sitting, standing and sleeping position. And we advise the patient for physiotherapy. So patient is going for muscle strengthening exercises. So 90%, more than 90% patients improve after conservative management. And what's the advice which is given? Improvement in postural sitting, standing and sleeping position. Okay. So improvement in postural sitting, standing and sleeping position. Second, muscle stretching and strengthening exercises are advised. Muscle stretching and strengthening exercises. Okay. After that, question is asked that what are the indications of surgery? Now see, if there is no improvement after conservative management or sometimes there is worsening of symptoms in these patients, we go for surgical treatment. Whenever there is some kind of anatomic abnormality, if the patient is having vascular form in which there is compression of artery, compression of vein, and if there is significant nerve compression, which is detected by nerve conduction studies. So see, what are the indications for surgery? Indications for surgery in thoracic outlet syndrome. So if there is no improvement after conservative management, or sometimes there is progression of sensory and motor symptoms. Clear? If there is excessively prolonged ulnar or median nerve conduction velocity, it means there is significant nerve compression. If there is involvement of subclavian artery and subclavian vein, so narrowing or occlusion of subclavian artery, and in certain patients because of compression, there is thrombosis of subclavian vein. So in vascular form, generally we have to go for surgical intervention. And any patient who is having anatomical abnormality like cervical rib, fibrous band, so in those cases we have to go for the excision. So this is how we manage the patients of thoracic outlet syndrome.